So we were approached in the second week of March, just before we started getting COVID patients, by Dr. Erickson to see if we could come up with some projections that would tell us the answers to the central questions at the beginning. How fast will census grow? When will it peak? And how high will it go? And the most immediate concerns were the total number of inpatients, the critical care unit, and then ventilated patients. And you can see here, this is an early version of one of those projections, and there was just a vast amount of uncertainty when things got started. So I'm going to hand it over to William to describe how we went about the process of developing this model.
Thank you, Dan. So before we dive into the context of how we developed this model, I want to mention one of the problem at the very beginning when we touch on this projects, which is which type of model that we want to go after. At that time, we have two options. First type of model is a traditional epidemiology model like SIR model. And the second option is like a machine learning time series forecasting model like Facebook ProFat model. And we eventually go after the SIR model because of the first reason is because this SIR model is entirely built up on the understanding of the structure of pandemic and also understanding the pattern of infections, which whereas the machine learning model has to learn from the data from scratch. So this is a very big advantages by using SIR model. And the other reason is we choose simplicity over complexity. We think the SIR model is much more easier to explain comparing to explaining a black box model, machine learning model. So now we choose what type of model that we want to use. Let's talk about how we develop this model. The steps can be broken down into 3 steps. The first step is to play around with the SIR model. For the first step, we want to get a sense of how many daily new hospitalization we would likely to get in the next 120 days. And to get this number, we need to have main 4 assumptions, which are MSK's active cancer patients who've been treated in MSK, for example, in the past 1 year, and we need to make assumptions on doubling time, recovery time, and social distancing. Okay, so now we get the daily new hospitalizations volume. We need to further break down this number into 3 different cohorts, which are floor inpatients, critical care patients, and ventilator patients, because they utilize very different critical resources. And we need to make assumptions on the percentage of how much of these each cohort is accounting for the overall daily new hospitalization volumes. And in the second step, we got the daily new cases for each of these 3 cohorts. And for the step 3, we need to get a sense of what the daily census of these 3 cohorts looks like. Now we have the daily new cases. We need assumptions on the length of stay that these 3 cohorts of inpatient will spend in the hospitals. And we made assumptions for each of these 3 cohorts, and eventually we got the daily new census. Okay, next slide, please. Now we get the model that output the daily census for COVID-19, and we need to do daily collaborations. And we do daily collaborations on mainly 2 parts. The first thing is the doubling time. By comparing our models doubling time with MSKs and also models doubling time with MYCs. We're doing this is trying to make sure our daily new case increase or decrease speed is at the right pace comparing to MSK and MYC. And after we make sure the new case increasing decrease speed is at the right pace, we will do collaborations on the census by comparing the model census with the MSK census. This is trying to validate that our assumptions on the length of stay are on the right track. And the third thing is explaining discuss the possibility of model updates. That is based on that if we observe there is an off track on either doubling time or census for a period of time, we will then see if there is a possibility that we can make some changes on the models on either doubling time or the length of stay. So next, I will hand over to Dan. He will talk more about how we collaborate with other groups based on this model.
You're on mute, I think.
Sorry about that. So the projections were one important piece of this, but they were not the only important piece. And we found that consistent and careful communication was really another essential part. And as Dr. Erickson touched on earlier, visually communicating what was going on really let us distribute to a large number of people what the implications of this might be. And so as Jonathan and Theodora shared, this was shared every single day during the Hicks meetings so that everyone knew, what it is we thought the trajectory of the census would become. In addition to that, we also needed to get feedback from all the groups that were hearing this and to understand, well, do you, for example, William started separating out the different groups of critical care patients because we realized there was a new need for this. And so we were constantly developing what the projections were, but making sure people understood, what they meant. And here you can just see what the daily communication channels were between us and between Hicks. So in addition to being shown on Hicks every morning, we also had a separate meeting with pharmacy, supply chain, HR, and digits every single day. And part of the reason for this is that we weren't really trying to change the model very often, but we had lots of discussions about what were the changes, what were the underlying trends, and what did we think might happen. And so we wanted them to understand, as people who were planning, some major decisions, whether or not we thought that there were other trends, even if our projections weren't actually going to change. So when it comes to the decisions that were downstream of this chart shows a very early version of our critical care census. So I think this line probably comes from mid-March. And you can see it spikes all the way up at 118 critical care beds. So on top of this projection line, we see reference lines that correspond to spaces, which is basically decisions that we would have to make about how to reallocate space. So you see the bottom line is the standard capacity for critical care. And then as you move up, how many more beds would we get if we reallocated, M6 or the PICU or things like that? Now, it turned out that later on in April, we downplayed and we revised our projections a lot. But this sort of contingency planning was sort of the means that we took to explain what steps might needed to be taken. Some of the other decisions included releasing 35 vents when we realized that the needs wouldn't be as high as we originally feared. Retraining APPs to be able to provide critical care services as that became more strained, and then guiding critical PPE and pharmacy orders. And there were many other decisions that we think, that were downstream of this, but those are just a few. And so I will pass it to Isaac now to talk about some of the other aspects.
Yeah, so what were the main learnings? So let's start with the fact that really early on in March, we were very wrong. We were very, very wrong. So the blue line is our original model, the orange line is the second model, and then we settled on the third model. And in discussions with Biostat's leadership, Dr. Begg told us that it's actually not possible to forecast, not possible, it is impossible to know how much an epidemic will peak because the information is just not out there. You don't know really what the transition rate is. There's just not enough information. So then the first question is, why even do this at all? if it's not possible. So, um, you know, this is an exercise in managing and understanding uncertainty. The exercise of looking at this every single day and reflecting and trying to see starts a conversation about what is the shape of it. It's going to grow exponentially. It's going to peak. It's social distancing is going to happen. That peak is going to start lengthening. And so we could start communicating and understanding patterns that we're expecting to happen, even if we're not wrong. Another really important thing was this was sort of one source of forecasts that everyone used for planning. And so when it changed, everyone was able to change against the one source. So we didn't have a high or medium or low. We had to have one information as a useful guiding point for how people would do it. And I think eventually we ended up in the beginning of April with a pretty good forecasts. But the general idea is, even in the face of profound uncertainty, attempting a forecast, understanding the shape, the behavior, and communicating that is still very valuable. And so what other lessons did we learn? So there were a few things that were really unique here, which is I've never seen such quick organizational alignment and silos breaking down so quickly. I mean, there were analysts from 8 departments in this presentation. So very rapid alignment of priorities, immediate breakdown of silos. And there was also, we really tried to manage the inherent uncertainty in model fallibility. And a lot of it was with this sort of continuous feedback, this daily looking at the data, this daily updating, the conversations about what might this mean. How do we incorporate social distancing? Oh, social distancing wouldn't only lower the peak, but it would lengthen it, which is something that we saw. And the first two are really a function of the crisis, and it's an open question of can we and how might we be able to do this outside of a crisis, because this was clearly a function of the crisis. But really the other things are, weren't related to a crisis at all.